Okay, thank you very much for this introduction. I was asked to present the high volume part of this controversial discussion, and the title I was given is Big is Beautiful. Here are my disclosures. I have no disclosures, but rather than that, I work in a high volume center, of course, so I make a strong plea, of course, for high volume centers. This is our annual caseload, which has been above 100 cases for years now, and we overlook an experience of over 2,000 cases so far. So the time for Barbie dolls is definitely over, if you ask me, and I will convince you during the next couple of minutes that big is actually the new beautiful here, and Dr. Batrami will have a hard time to conquer this. What is a high volume center? So let's talk about definitions first. High volume is not strictly defined in the literature. However, if we look at ISHLT data, centers consistently doing above 50 cases per year over a time period of 15 years are limited to 15 centers worldwide. In the literature, high volume centers are frequently defined as 30 cases or more per year. So how it all began when talking about volume center effect, it took me quite some time to go back and find the first publication. This was very interesting for me to learn. This was published in the New England Journal of Medicine back in 1979. And the hypothesis of this Stanford group was at that time that they found from the industry that there was an experience curve in terms of unit costs and production time in the airplane and automobile industry, where they could see that those costs and unit time decreased with a higher experience and a higher caseload. So what the hypothesis was, whether this would also be the case in surgery. And they looked at a huge cohort of patients, over 800,000 patients, grouped them into 12 surgical procedures, included 150 hospitals, and came up with the conclusion that for complex surgical procedures such as open heart surgery, vascular surgery, hip replacement, there is a profound volume center effect. But this is not true for easy cases, such as cholecystectomy or uncomplicated appendectomy. Based on this first publication, 1979, here come the publication from the Transplant Medicine Heart, were the first one describing a volume center effect in 1994. Liver transplantation, also New England Journal of Medicine paper, 1999. Continued kidney transplantation, 1999. Pancreas transplantation, 2004. So you might ask, what about lung? Lung, first publication on lung transplantation describing a central volume effect was not done before 2009. But this was a large study on the other side, looking at UNOS data of over 10,000 cases, including 80 centers, and they found that, of course, there is a profound central volume effect. And if you look, the survival curves clearly separate. The limitation of this study was that a high volume center was defined as doing 20 cases or more, which is definitely not the thing we would define as high volume today. However, 2016 update publication, again the UNOS data set, and you can see that now high volume centers were defined as 40 cases or more per year, and again the survival curves separate, high volume centers doing better, having a better outcome. So I could actually stop my presentation here. But unlike some politics, I would like to look below the surface and give you a little in-depth analysis. And I thought about how to do this, so I grouped the lung transplantation into three main components. The first one being patient selection, the second one surgery and perioperative care, and then the long-term follow-up. And I'll show you data for each of those components stating that working in a high-volume center is better than in a low-volume center. What about patient selection? This is critical, and if you look at the publications that are out today, there's a profound difference in patient selection in low-volume versus high-volume centers. This starts with the underlying diagnosis, low-volume centers having a higher proportion of COPD patients in their waiting list, high volume centers doing, of course, the PH patient and complicated IPFs. But there's a difference also in bridging. This is true for mechanical ventilation as bridging and ECLS as bridging. High volume centers have a higher proportion of high LAS patient, kind of underlining that more complex patients are done in high volume centers, and then retransplantation is something which is much more frequently done in high volume centers, of course. So let's step one step back and from the theory and go into the practical examples. And I just pulled out two examples which I found interesting from our patient cohort, which of course in terms of indication can be debatable, but should show you that what high volume centers with their experience over the years can actually offer patients. This is the story of a female girl who is meanwhile well known in our center. She received her first transplantation back in 1995 when she was a small CF girl, and meanwhile was retransplanted 3 times. She gained 25 years of additional lifetime in very good quality, and the picture on the right-hand side is her cycling yesterday. Second patient, probably even more controversial, 6-year-old female child. In January 2019, underwent an influenza A RADS, went into septic shock due to bacterial superinfection, and had a very rough course thereafter. Here you can see the first picture with toes getting black. And she was resuscitated with a VA ECMO, changed to a VV, and then changed to a central ECMO combination, kind of survived this critical first period, stabilized from her sepsis, and was transferred to our transplant center with a picture like this. And against all odds, we decided to transplant this young girl. She received a bilobar transplantation and is meanwhile out of the ICU doing fine. You can see her having a drink on the right side. She's on a normal ward. She can walk. Her finger and toes have completely recovered after a bridging period of 93 days on 3 different kind of ECMO components. So this is something you can do in high volume centers. But what about the second component, perioperative treatment surgery? Let's start with ECLS bridging. There are 2 papers around showing that it matters whether you do ECLS bridging in a low volume center or you do it in a high volume center. Again, the survival curves significantly differ between high and low volume centers. But it's not only the survival, more importantly, how are patients bridged? And awake mobile bridging, something we all aim at the moment, because this has a significant impact in the perioperative course of those patients, have been only exclusively reported by high volume centers. And this is so important for the patient to keep them awake, to keep them ambulating until they receive their transplant. What about the surgery itself and complication rates? Let me just draw your attention to the right-hand side. Actually, there is no difference if you look at the major complications between low volume and high volume centers. This is something I wouldn't have expected. I would have thought, low volume centers less experience, more complication. That's not true when looking at the literature. However, if a patient actually has a stroke, and then you have to look at the right-hand side here, the survival rates are significantly better, the odds of surviving is better. And this is true for renal failure, this is true for stroke, true for reoperation, infection, and rejection. This is again data from Vienna, and I found this very interesting, plotting the annual caseload on the x-axis and then looking at the 1-year survival, and you can see that with increasing number of transplant, our 1-year survival significantly improved over the years. And on the other hand, the airway complication rates as a surrogate marker for complications decreased, and we are now down to 1% of airway complication rates. This is a nice publication from the Ohio State University. Don Hayes kind of combined 2 different factors, ischemic time and volume center effect. And we've heard before that ischemic time of 6-7 hours might be critical, but this is only true for the low volume center. This is quite a complex statistical evaluation. But if you look at the odds of dying then the low volume center have an increased hazard ratio for mortality, but this is not true for a high volume center. They can easily go up to 9 hours, 10 hours cold ischemic time, and their patient do not have a higher mortality rate. What about long-term follow-up? Also, we have evidence for long-term follow-up. If you look at truncated survival analysis, and this has been recently published in the European Journal, if you do a conditional 1-year survival and look at survival beyond this, you can see that high-volume centers offer a better long-term survival to their lung transplant patients than low-volume center. And this is mainly due to a decreased rate of infectious deaths, decreased rate of deaths or respiratory failure. The story continues. Transplantation is not transplantation anymore. We now go into detailed analysis. What about PH patients? What about CF patients? There is at least one publication in the CF population showing that if you get your transplantation in a center experienced with CF, your outcome is actually much better. And this also has a significant impact on economy and costs of the procedure. Of course, this is a publication from the US where costs are frequently monitored. And I found it interesting to learn that the same procedure, the standard lung transplantation in a low volume center, is $13,000 more expensive than a lung transplantation in a high volume center. So yesterday evening, I kind of Googled what I could do with $13,000, and I found that actually at the moment you can buy Jack Castle for 13,000 euro. This is a recent article in the Bloomberg Business Week. Just transferring a patient from a low volume center to a high volume center. What about dedication? I think you will hear a lot about dedication by Dr. Batrami, and summarizing his talk up front. Looking at PubMed, I found 0 hits if I searched for dedication and outcome in lung transplantation, so there is no evidence, whatever you will hear after me. Why? Because, of course, dedication is a prerequisite. We should put a maximal dedication to every patient, but this is independent of course, the volume effect. It's just a surplus you have when being transplanted in a high volume center. So in conclusion, healthcare providers, health politicians, they need to understand the importance of center volume. We should consider changing to a volume-based referral concept, especially in the Eurotransplant region. There might be a need for reduction of the number of transplant centers, and for small countries in Europe, the role of supranational system should be discussed. Thank you very much.